think it will take only a minute.
Okay.
Dr. Damle is already there. Dr. Akshay Damle is already there.
Okay.
Dr. Mitesh Gala is already there.
Okay.
So we are just waiting for Dr. Mukadam. Vishwajit?
Yes, sir. Harshal there.
Harshal, just wanted to check about Dr. Abdul Shakur Mukadam. Is it
Yes, sir. I talked with him. Yes, sir. Just 5 minutes he will join, sir.
Yeah.
So Shakur sir is there, sir.
Sir, can we go live on audience link?
Yeah.
Yes. Chafre,
Yes.
sir, can we start, sir?
Yes, we can start. I'm here only.
Yeah. So, good evening, everybody. On behalf of Alkem, the fifth largest pharmaceutical company in India, I am Mandar Bide here, Zonal Sales Manager, Alkem. I welcome all our panelists as well as our audience for today's Views Vildagliptin panel discussion. I will introduce the panelists for today very briefly. We are very fortunate to have very experienced panel today for Views Vildagliptin panel discussion. Our moderator, I welcome our moderator, Dr. Hari Safree. Dr. Hari Safree is an intensivist, physician intensivist and critical care specialist at Global Hospital Parel. He has over 15 years of experience in critical care medicine as well as the chest medicine, and his special area of interest is chest medicine in internal medicine. So he will moderate the session for today. He has got several publications to his credit in chest medicine as well as in critical care medicine. He is a member of Critical Care Society of India. So welcome, sir, for today's panel discussion, and we thank you from the bottom of our heart for having accepted our invitation as a moderator for today's discussion. We have our first panelist today, Dr. Abdul Shakur Mukadam. Dr. Mukadam is a known figure in the area of internal medicine. He's a graduate from Liverpool University, and he has been trained in King's College London, and he has worked in various countries, particularly the Gulf, in Saudi Arabia, and he will enlighten us about today's panel discussion, and he will play a vital role in today's panel discussion today. So thank you very much, sir, for joining today as a panelist. Our second panelist is, of course, Dr. Akshay Damle. Dr. Akshay Damle is MD Medicine. He's attached to Global Hospital. He's attached to Shushrusha Hospital and Dhanvantari Hospital. His keen area of interest is, of course, diabetes and thyroid. So thank you very much, sir, for having joined today for today's panel discussion. And our last panelist for today is Dr. Mitesh Gala. Dr. Gala is an internist. He's MD Medicine, and of course, he has his clinics in Lower Parel and Khar, and he has over almost 5 years of experience in the clinical practice. So, with this brief introduction, I hand over the session to Dr. Hari Safree for further discussion. Thank you very much, sir.
Thank you, Mandar, and thank you, Alkem, for giving us an opportunity to discuss all these things here about DPP-4 inhibitors. We'll be discussing, and we have an eminent panel with us, which will share their experience as well as their expertise. So, I think if everybody has joined, we should start the proceedings, basically. So, it is going to be a question-answer session where I will be throwing some questions to the panelists, and they will be answering the questions. And if the audience has anything to say or any queries from their side, or they want to add something, or they want to ask question to panelists as well as the involved members, then either they can put the question in the chat box that is provided, or they can unmute themselves temporarily and ask the question directly also. That is okay with us. Yeah, so I would say first question I would will go to Dr. Abdul Shakur, as introduced, a well-known faculty and an infectious disease specialist as well as diabetes management. So let us discuss the basics first, basically. So what will be the mechanism of action of DPP4 inhibitors? We all know that, but just to discuss briefly to set the ball rolling. Dr. Abdul Shakur.
Yes, Dr. Hari Safree again, welcome. Last time also we had with from Sanofi, and this time from here in Dr. Akshay Damle ji, and one more, I think he's not there, huh?
Dr. Mitesh Gala.
Mitesh Gala, I think he's not visible here, maybe. So, and again, all came people.
I would request Dr. Gala if you can, switch on your video, sir.
He's in a mute as well as.
Okay. No problem. Dr. Galaji is also there. See, basically the question asked by Dr. Hari Safree ji, basically it is a dry question as well as a pathophysiological question. But when he asked the question, and definitely, and even we all aware, basically here there are two things in this, okay, how it inhibits the mechanism. One is GLP-1 analog and one is GIP. So a GLP-1 analog, basically, as we aware, all of us, okay, basically, if you see exactly glucagon-like peptide, GLP-1 analog. And other thing, if you think in GIP is nothing but glucose-dependent insulinotropic peptide. So this basically both inhibit, and the DPP4 it works. And exactly if you see, we know as sitagliptin, vildagliptin, these are well-known products of this DPP4, and which mechanism of action by two things. One is GLP-1 and one by GIP-1. And it inhibits in human beings, and thus it works. And because of this, directly or indirectly, we get many benefits. Like we'll talk in detail afterwards when you will ask some other question, like why we should start DPP4, why this mechanism are there. Because basically previously people used to start some medication after sulfonylurea, metformin, then they used to wait for DPP4. But here, the thing is changed. Okay, we should not wait till the side effects of other thing comes and patient gets suffer other complications. So I don't know exactly some other question for other panelists, so I don't want to cover much. So in short, this takes care of GLP and GIP, and by this mechanism, it inhibits and we get benefit, and the sugar get under control. And the main benefit of this, patient doesn't get hypoglycemia, will get, but less hypoglycemia. Even weight-wise, it's a weight neutral. And if you think in terms of HbA1c, also it will be under control.
Okay. Yeah. So as rightly said by Dr. Abdul Shakur, there are two pathways basically through which it is acting and helping the sugar control. So as we see, there are a lot of patients of diabetes. I would say the maximum number of diabetes. So in India is called the Makkah Medina of diabetes, basically, because all over the world, if you see the number of patients and the severity of diabetes in India is more than what we find in other parts of the world. So that also brings to a question, basically, are Indians different from others in response to DPP4 inhibitors? So like other people in other countries or other races, they may react differently. What is your experience, Dr. Akshay Damle? Are Indians different from others in response to DPP4 inhibitors?
Good evening to all of the panelists, and good evening to sir. And thank you for inviting me for this session. Regarding the question about the Indians being different from other Western population, so there are many demographic studies which have been done which prove beyond point that there is a genotypic and phenotypic relation compared to Indians with respect to the American, Caucasian, Hispanic population, and the mode of diabetes onset with respect to Indians and Westerners is also different. So Just diving into the depth of diabetes pathogenesis, it has been postulated that in Western population, the onset of diabetes is mainly because of insulin resistance, whereas in Indians and mainly Southeast Asian population, it is a insulin secretory defect. So definitely the choices of medicines, the choices of other treatment modalities and the response to treatment is going to be different. Also, hormonal studies have been done which show that adiponectin levels are low in Indians more than the Western population. There is also a Indian meal pattern which is very important with respect to our carbohydrate load, the amount of food we consume, the timings of our meals, which lead to the fact that our treatment has to be customized according to our population as respect to what is exactly prescribed by the other associations apart from the Indian Diabetic Association. So yes, sir. So we definitely are different in terms of diabetes, and hence the imperative fact that we have to discuss more about the diabetes because we are a diabetes capital of the world.
Yeah, and as rightly said by Akshay, whenever there is question comes to treating diabetes adequately in any patient, you need to identify the pathophysiology of diabetes in that patient, and you need to address that pathophysiology with whatever medication you are selecting. And then I think it will be a tailor-made approach to an individual rather than guidelines will definitely tell you the pathway to walk, but you need to decide what will be appropriate for this patient, and you will have to screen everything from blood tests to his physical parameters to his BMI to his habits to his understanding, and also last but not the least, the economics of the patient is very important because if you prescribe some hi-fi drug with a very high cost, it will be a futile waste for him because he will not be able to take. Also, you should check his area of residence whether whatever you are prescribing is going to be available in that area or not. Because I have seen patients who come from the remote interior part of Maharashtra in search of better treatment of diabetes in Mumbai. If you cannot get a drug at their place, then there is no point in prescribing any medication which will they will not get, they will not follow. So it should be a long-term plan rather than a short-term plan whenever managing diabetes in any patient, basically.
Absolutely, sir.
So
We
that
cater
brings
to yeah. We cater to a
it has to be
vast.
tailor-made to the patient as per his requirement.
In Mumbai, we are fortunate enough to cater to all the strata of the society. So we have to deal with all those technical challenges, if I may put so, rather than just the medical challenges.
Yeah, medical part of it. Correct.
Yes.
Correct. So that brings to me the next question. As we all know, the treatment of diabetes stands basically for lifestyle modification, then exercise pattern, diet modification, and it forms the base of diabetes management for any patient coming to your clinic for diabetes management. And as we all follow the standard protocol of starting metformin as an initial agent to start and then gradually build up the dose to the tolerability of the patient as well as the fasting post meal values as well as HbA1c. There is no question that if the HbA1c is beyond certain values which are given in the guidelines, then you should start a combination therapy upfront. So that brings me to ask the next question to Dr. Mitesh Gala, who is another panelist with us today. In your view, what would be the suitable add-on to metformin in our practice, in addition to lifestyle modification, diet modification, and whatever we form as the base of diabetes? What would be a suitable add-on to metformin?
Yes, respected everyone, thank you for inviting me to the panel. Yes, so the first, I think, as the goals say, actually the HbA1c targets also have been revised for the Indian population also these days. And I think HbA1c alone, of course, does not play a the only role because I've seen a lot of patients who have their fasting and their postprandial levels within limits, though their HbA1c continues to be on the higher side. So that is probably due to their missing out of control because HbA1c will reveal a 3-month value, and usually we see a lot of patients who do a very stringent control over their diet over the last 3-4 before the 3-4 days of getting tested. They take their medicines properly, they follow their diet properly, and probably the fasting and PP values still come under control, which is not exactly unveiled by their HbA1c, which tends to be a little on the higher side compared to their fasting and their PP levels. So I think a most suitable, I think, add-on therapy that I usually consider is usually maybe adding sulfonylurea if the patients. So adding a sulfonylurea also at times becomes a little more difficult if the patient is elderly, he has a risk of hypoglycemia, maybe very elderly, very fragile patients, low lean body weight mass patients. Yes, so a reasonable, I think, add-on therapy would be to put a patient maybe on a DPP4 inhibitor as an initial monotherapy also, or maybe an add-on therapy to metformin also. And apart from that, there are a lot of other spectra of drugs also that we have. So, but the usually the monotherapy is
I think there is some technical problem.
glycemic control, and especially being a little more stringent, especially in HbA1c levels above 7 for sure. HbA1c levels between 6.3 to 6.8 probably can be due to a lot of dietary factors through the course also. So I think that may be corrected with good diet control, of course, with good weight loss regimes or with good lifestyle modifications itself. But I think a gradually increasing HbA1c level usually will advocate to add a therapy, because usually I do not add treatments of SGLT2s or maybe even thiazolidine or maybe even drugs such as or anything. So possibly, I think the second add-on therapy for me would be to add a sulfonylurea, if advisable, or not. If it's not falling under the patient's regime, then probably put him on a DPP4 as the starting agent of choice.
Yes. Yes, Dr. Mitesh has rightly said, as an age-old remedy, sulfonylurea, and we have seen a lot of trials also which
Yes.
cleared the doubts about sulfonylurea. But when it comes to adding another thing, basically, I would add something which will help long-term control, HbA1c reduction, weight neutrality, then CVOT outcomes. These are very, very important things whenever you are planning something for a patient. And obviously, you need to see the underlying renal functions, whether underlying renal functions are normal, because most of the patients come to you with a burnt of diabetes where they already have a micro as well as microvascular complications already present when they present to you. So all these factors needs to be seen, and obviously whenever prescribing any medication for diabetes, your first and foremost plan should be to reduce the number of hypos. Any treatment plan has to have minimum hypos, then only it is said to be more effective and efficacious. And to see whether this SGLT2 the DPP4 inhibitors are properly placed as far as other concerns of adding another drug is concerned, there was a verified trial which we all know, and it has cleared a lot of doubts. So I would ask next question to Dr. Abdul Shakur. Verified trial results and any changes in our prescribing practice after the trial results had come, and how it has helped all of us in prescribing DPP4 inhibitors.
Basically, now before me, Dr. Mitesh has said correctly, and we have discussed before. I think you were there in Sanofi discussion also.
Yes.
Basically,
Yeah.
sometimes we should not forget that definitely even sulfonylurea and other drugs are also there, SGLT2, pioglitazone. But when you ask me regarding verified trial, definitely this trial tells us, like in T20 match, hit early, then you will get a good runs. So here also, if you aid vildagliptin along with metformin age early, it will be more better. Then instead of waiting, we'll aid metformin, then we'll go for aiding DPP4. So these verified trials, many companies like Novartis and this all came, and many, they have studied for this for last 5 years. We have result with this. Okay, early combination with metformin, if DPP4 is added, we get many benefits. Even the other benefits like less hypoglycemia, weight neutral, HbA1c will be under control, other protection like renoprotective, even regarding retinopathy, heart failure, and all this, like especially even in the case of sitagliptin also, they had study for TCOS also. Okay, that time cardiovascular safety was also seen. So in verify trials, if we just point out for only this study, early combination of DPP4 and metformin has got better results.
Yeah, that answers our question, and it has definitely helped. See, whenever you are confused about certain drugs, whether it will be efficacious or not, these trials, the trial results, whether there are p values were significant or not, how the trial was done, whether it was multicentric, single centric, whether it was blinded, double blinded. So all the qualities of a trial that should bring out good results for changing your clinical practice were all made by verified trial, and I think the results has helped us a lot, and that is how I think we are upfront using as Dr. Gala said, we can start it as a monotherapy also. It's not like that you have to have a combination therapy wherever appropriate you can feel. So that brings to next question to Dr. Akshay Damle. In your practice, what is your experience of combination of vildagliptin with other anti-diabetics whenever you are treating patients of diabetes?
Okay. So since commencement of my practice, we have been reading books, we have been studying all sorts of patients, and the only thing which comes to our mind is the physiology, understanding the physiology of diabetes. So here DPP4 inhibitors play a very vital role in the sense that they target the crux of the root cause of the problem, that is insulin secretory defect as well as insulin resistance, which helps in which places them in a very unique position wherein it can be used as an add-on therapy as well as a second line of therapy after metformin. So my personal opinion regarding vildagliptin has been really very positive. I myself advocate vildagliptin ahead of sulfonylureas, just for the mere sense that the quality of life associated with vildagliptin to the patient is much more better compared to sulfonylurea, with the very fact that chances of hypoglycemias are negated with vildagliptin, as well as the smoothness of the glycemic control, which has been absolutely neglected in the routine medical practice, is taken care of, because in our routine medical practice we only do fasting sugar and post meal sugar. Nobody talks about after breakfast or before lunch or dinner time sugar levels, and this brings to the confusion that HbA1c levels are high and fasting and post lunch sugars are normal. So here vildagliptin plays a very major role because it helps in smoothing out the glycemic control. It negates the the need for addition of other anti-diabetic agents. And as it is used OD or at the max BD, it is very fruitful for the patient, and it helps in increasing the compliance. So obviously, as an add-on therapy, along with metformin sulfonylurea or metformin TZD, metformin SGLT2 inhibitor, it is going to help. It's a no-brainer. But per se, metformin and vildagliptin play a very important role as compared to metformin sulfonylurea also.
Yeah, correct, absolutely. So definitely it is helping us in all this while about maintaining a normal glycemic as well as other benefits that vildagliptin has shown in the trials. So that brings to the next question. If you're using an agent, you should know about the drug interactions with the agent. So definitely it is a very important thing to discuss out here, because all those who will be using this agent should know their limitations whenever you are, because the patient comes with a lot of list of drugs already on panel before they, so they have underlying hypertension, they have ischemic heart disease, somebody must be having Parkinson's disease, a previous stroke, acute kidney. So all these drugs are already there with them. So my next question goes to Dr. Mitesh Gala. What are the drug interactions of vildagliptin with other drugs basically?
Yes, so now vildagliptin, as it belongs to the category, it does not inhibit or increase the levels of the cytochrome enzymes. So it's an independent cytochrome effect that they call it, of vildagliptin. So usually the patients that usually come up are usually a class of kidney related symptom patients who probably have a creatinine mildly raised creatinine levels. So I think eGFR then plays a very, very important role. Yes, eGFR of less than 60, I think we usually consider vildagliptin at a full dose, which then gets reduced with eGFR below 45 or eGFR below 30 levels. I think we use a vildagliptin dose of around 50, and probably it's less likely to be initiated with a eGFR value of 15. Though some people still advocate vildagliptin to be used at a dose of 50 milligram because it's less dialyzable DPP4 inhibitor. So at times 50 becomes a minimum dose then to be used. So in CKD patients, and of course in patients with liver cell injury or patients who have transaminitis, so patients who have OTPT levels like more than 2.5 times the normal, I think it should be considered. It should be used with caution with an absolute contraindication of SGOTPT levels being more than 3 times the upper limit of normal. And there are few drug interactions that have been mentioned, which usually increase a little effects of the vildagliptin molecule per se. They say a little thiazide like diuretics patients taking, I think, increase the levels of vildagliptin a little with very, very minimal effects. So I have not personally also encountered neither. There is too much literature also at present saying additive effects of drugs. Those, or you can also add to your to the whole thing, because vildagliptin, I think the only two things, liver and kidney, are usually the things that I personally look out for. Otherwise, I don't think any other patients on any other drugs, usually we shift the dosages of the vildagliptin molecule per se.
Yeah. So definitely very good, very well said, Dr. Mitesh. As we use any drug in our clinical practice, we should know that whether it is in inducing of CYP450 or not, because if it induces that enzyme, then there are a lot of things that can be go to a wrong end, as rightly said, it's absolutely a contraindication if you have a patient with transaminitis with SGOTPT value more than 3 times normal, and you have to use it with caution. I'm not saying it cannot be used in patient with acute chronic kidney disease or any renal problem, but the dosage utilized in them has to be, say, I think 50 mg OD is what I usually use in these patients. I try to manage with other agents, or if it comes to that, adding insulin will be a better option for patients who are of chronic kidney disease, because we know how vulnerable they are for hypoglycemias, and if the control is inadequate and how fast the creatinine goes up and what happens to them. So definitely these are the things. But if it comes to using vildagliptin in patient with atherosclerotic cardiovascular disease, so Dr. Abdul Shakur, the next question is coming to you. Any reservations as regards prescribing vildagliptin to patients with ASCVD? So do you consider any reservations where you have a patient who has underlying ASCVD? Do you have any reservations in using vildagliptin in these patients?
Basically, see, vildagliptin is, if you see, or otherwise DPP4, there are like before me, Dr. Gala said regarding CKD and all. See, if you see, there are different varieties. Suppose if comes of cardiovascular safety, if you see sitagliptin like TCOS, it will be better. But if you see in terms of CKD, linagliptin will be little better in case of CKD wise. But in case of this thing, cardiovascular safety, if you think sitagliptin, they have TCOS study. So, but vildagliptin as a whole, okay, there is not that much any reservation. Okay, even it is a safe molecule you can give, but just few things we have to keep in mind. Even few people is to say like for DPP4, especially CETA and this, okay, previously pancreatitis and all this thing. But I don't think, even if you think in terms of other benefits, like even other than controlling sugar, it also helps to reduce blood pressure. Other renoprotective effects are also there. So as such, there is no any reservation is SCVD user asked.
Yeah, we can safely use in these patients, and there should not be any reservation wherever we are considering patients with ASCVD. But it's always a question whenever you get a patient of diabetes who has long-standing diabetes, and they already have a developed diabetic nephropathy as a complication, and they come with very high creatinine value. And so my next question goes to Dr. Akshay Damle about renal safety of vildagliptin, though we have discussed intermittently about these issues whenever we have discussed other question. But to specifically discuss about that issue, do we need to modify the dosage of vildagliptin with declining GFR? Because you may get a patient who has a GFR, say, more than 40 to start off with, and as the disease progresses and other thing progresses, the GFR, for example, goes down to below 10. So how do you modify, and what is the renal safety of vildagliptin?
So there are many adequate studies which are done which show renal safety of vildagliptin compared in patients with CKD. Um, I personally, and there is a lot of data which shows that we have to dose modify for vildagliptin in terms of the EGFR. So more than 60 of EGFR, we can safely use up to 100 mg of vildagliptin, and less than 60, there are charts available everywhere across various studies which show that less than 60 we reduce it to half, less than 45 we reduce it to 60%, and less than 30 it is contraindicated in a general perspective. In terms of EGFR less than 10, definitely it is contraindicated. Nobody is going to use it. And less than 10 also in one point to note that we get, and also you must be coming across many patients in ICUs, acute kidney injury patients, say patient with a normal creatinine or maybe say borderline high creatinine and creatinine jumping to 2.4 patient of fever is considered to be a EGFR less than 10 for that while. So obviously we are going to stop vildagliptin at that point of time, and once the kidney status gets back to normal, we can again resume the dose of vildagliptin. But in all general perspective, addition of vildagliptin in a borderline CKD patient has to be done with a pinch of salt. There are many nephroprotective DPP-4 inhibitors available like linagliptin, as what Dr. Abdul Sir said, which is totally safe as per studies. And if given a choice, linagliptin would be better, especially in CKDs. But in borderline cases of CKD where EGFR is between 30 to 60 and patient is fairly controlled with vildagliptin with dose modification, we can continue vildagliptin.
Yeah, as rightly said by Dr. Akshay, we need to be careful about it. And as it goes without saying, whenever you are following a patient of diabetes, in the future follow-ups, you usually give them list of tests, and all these patients has to be monitored about creatinine, blood urea nitrogen, electrolyte at every visit, because you never know when the creatinine will go up or down. You never know these patients when they go home and they get some aches and pains, so they will go over the counter medication. They can take any NSAID and that can hit the kidneys badly. And if you don't keep on checking, you'll not come to know what is happening with the patient, and then you might go on the other part of the curve, which can be dangerous to the patient as far as the renal disease and other things are concerned. So definitely you need to monitor the stage of renal disease the patient is in. So that will definitely help you in knowing what dose to be used. So that brings to the next question to Dr. Mitesh Gala, wherein I'm just trying to ask him to highlight about how you use vildagliptin at various stages of renal disease, because the starting dose might be different, the starting renal function might be different of a patient coming to you, but they might worsen whenever they are following up. So how do you use vildagliptin at various stages of renal disease?
Yes. So now vildagliptin, as we discussed earlier, so vildagliptin above 60 or normal EGFR, I think it can be used up to a full dose of 100 milligram per day. Yes, patients below 60 also we use the full dose only up to till the EGFR reaches below 55. But I think just talking about the EGFR, especially in diabetic patients, I think a lot needs to be considered about the stage of the renal involvement that the patient falls in also. So patient is in a stage of microalbuminuria, macroalbuminuria, as you already highlighted. So I think that also plays a very, very important role, because the patients coming in with diabetic kidney disease, I think will be a lot later in the progression course. I think that needs to be halted with the other medications also during the course of his turn of events from micro to macroalbuminuria also. So yes, of course, then patients presenting with diabetic kidney disease who are progressing progressive decline in their EGFR functions. I think a lot of emperor trials and a lot of verified trial, emperor trial, I think a lot of trials have come in with the use also of SGLT2 with use of DPP4 inhibitors these days. Yes, so a lot of now trials are coming whereby they are saying use of SGLT2 with DPP4 in reducing the severity or reducing the time duration required for the deterioration of the renal function. A lot of doctors are using empagliflozin also along with DPP4s. Yes, but my usual therapy, if a patient usually comes in with the EGFR directly of below 45, I think I would still prefer adding directly a linagliptin rather than vildagliptin for the initial use. Because linagliptin, two advantages linagliptin offers, I think, is hepatically safe also and renally safe also. It has so it can be used in all stages of CKD patients also. So linagliptin is a very safe, renally safe molecule. Then probably in a patient who has worsening renal function over a period of time, or if a patient comes with a EGFR of 60 and then he's progressing to 45, still I would consider to put him on vildagliptin. But if I feel that deterioration is happening too rapidly or it's not sustained, then probably I will switch over the patient to linagliptin for, because the patients then following up with you then at times becomes a little more difficult, and we do not want the patient again to be encountering any side effects due to vildagliptin overuse also per se. So I think the the choice between the use of gliptin will also depend on the how rapidly the patient is deteriorating over a period of time. So linagliptin becomes a safer molecule than compared to vildagliptin, of course. And sitagliptin, of course, a lot of studies have shown, if you just compare the molecular efficacy of sitagliptin versus vildagliptin, I think vildagliptin holds a little more higher compared to sitagliptin. Of course, not in the cardiovascular outcomes per se, but yes, the molecular efficacy, as they say, empagliflozin is a little more efficacious compared to dapagliflozin. Yes, so as the molecular efficacy, I think vildagliptin stands a little touch higher. And of course, linagliptin then becomes very, very safe drug to add in renally impaired patients who directly come, and of course, then to put them on insulin and maybe a DPP4 such as linagliptin. I think that will be a more safer therapy rather than continuing vildagliptin over stages of progressive renal involvement.
Yeah, Dr. Videsh rightly said, and I think that has cleared a lot of doubts among the audience who is attending this panel discussion about how to handle this drug whenever patient is having underlying renal disease, as well as whenever the patient has underlying renal disease which is progressing, and then we need to monitor and stage the kidney disease, stage the EGFR, and then change our dose as per the need of the patient. We have seen diabetes in Indians, and the age group that it involves varies a lot. We have seen type 1 diabetes in young individuals. We have seen type 2 diabetes in individuals which can come any part of their life, of strong family history. Then it comes because they are more aware and they keep on checking their sugars routinely, they come to know. But there are patients who are diabetic, had maintained their sugars very, so there are elderly patients, and I think a major chunk would form by elderly patients whenever it comes to managing diabetes in OPD practice. So we should always think about an elderly age group because they are more vulnerable for hypos. They may be staying alone in their home. If they develop hypoglycemic episode, then they can become comatose. And I have seen cases in ICU wherein the patient was sleepy, not responding for more than 24 hours. The relatives broke the door, then brought the patient, and we found that sugars were unrecordable. They were just recorded as low. Even the value was not being given by the glucometer. So definitely, whenever selecting any drug, we need to target this population also. So that brings to next question to Dr. Akshay Damle. Vildagliptin and its safety in elderly patients.
Yes, sir. So vildagliptin is generally considered to be a safer molecule in elderlies. The reason being that elderlies, there is a tendency of polypharmacy. They are comorbid, they have other comorbid conditions leading to other polypharmacy. And generally, it has been seen that vildagliptin has lesser amount of drug-drug interactions with the routine medicines which are routinely prescribed. Also, as you rightly said, chances of hypoglycemia is extremely low compared to other drugs like sulfonylureas or repaglinides or insulin with vildagliptin. And safety and side effect profile is the priority. I would say it is the utmost priority when we prescribe any drug, especially to the elderly patients, so as to make sure that at least your drug does not harm your patient more than at least they can do any good to them. So for elderlies, vildagliptin will be a good choice. Also, the smoothness of the glucose control will be there. Many elderly patients will come to you with loss of appetite, where vildagliptin being a glucotropic molecule it will help in physiological control of the glucose, the blood sugar levels, according to the appetite of the patient. So where if the patient has more carbohydrate load, the amount of insulin released and the amount of insulin secreted by beta cells will be mitigated. The loss will be mitigated with DPP-4 compared to the elderlies, wherein they do not have much of a appetite, and hence chances of hypoglycemias or any other serious side effects encountering in the elderly patients can be minimized.
Yeah, absolutely. Well said, Akshay. And as he rightly said, and I think we should follow the principle, do no harm. Whenever you are coming in practice, if you cannot do good to your patient, please don't do any harm to them. So we should be very, very careful while prescribing drugs to elderly. There's a polypharmacy ongoing. They may not be independent. There may be somebody taking care of them at home, which may not be available on time to take the drug. So as far as taking the drug and the frequency of the drug, administration of the drug, availability of the drug, as well as the incidence of hypos, all these factors needs to be taken care of whenever prescribing an elderly. So that brings to the next question, wherein we know that all the diabetics will have atherosclerotic heart disease, will have hypertriglyceridemia. So dyslipidemia is very, very common in patients who are diabetes mellitus. And as we all know, the incidence of fatty liver is very, very is highly increasing, because I think the awareness is increasing. There are a lot of sonologists who are upfront reporting grade 1, grade 2, grade 3 fatty liver. And definitely, if patient has an hepatic dysfunction underlying, but you need to check for this. You need to check the liver function test. You need to do ultrasound of these patients whenever they are being screened initially for management of diabetes. And if you find that this patient has a fatty liver, this patient has transaminitis, or this has some previous history of jaundice or any other HBV positive already before they come to you. So all these patients will have some hepatic dysfunction. And that brings to the next question to Dr. Abdul Shakur about the safety of vildagliptin in hepatic dysfunction.
Now, many things really you have discussed regarding polypharmacy, comorbidities, and really I have done my diploma in geriatric medicine. So I know when I was in UK, they used to ask, okay, why you check this medication? So it was correctly said, okay, there are elderly people, they have comorbidities and they are taking lot of drugs. And so because this, we should know, okay, either this drug is given to elderly or any patient, okay, what about this thing? So basically, vildagliptin mostly it is excreted through kidney. So it is, if you see, only we have seen in DPP-4, sitagliptin somehow it has got liver toxicity, but as compared to vildagliptin, it is safer. Even if you check liver enzymes, it has not increased in case of vildagliptin. So in terms of vildagliptin, in case of liver distance, definitely it is a safer side. So definitely we can give, even few people say no need to reduce the dose, even 50 BD we can give. Sometimes if like that, some people are cirrhotic, alcoholic, mostly nowadays, many people they are alcoholic, and because of that, one of the cause of alcoholic is cirrhosis. And because of that, and even some people are NFLD, and because, or we can say NASH. So because, but even though vildagliptin has better safety profile in the case of liver, sitagliptin you have to take care, but vilda it is safer.
Yeah, absolutely. As everything described in later part of the diabetes, whenever the diabetes becomes chronic and uncontrolled, then NASH-related complications and then associated things, liver dysfunction as well as. So all these things needs to be taken care of before prescribing any drug. And then I think, as rightly said, so we have basically everything covered about vildagliptin use. And as we all know, it's a very safe molecule. It can be used in elderly. It can be used in patients who are renally compromised, but not totally renally compromised. We know that it can be used in hepatic dysfunction. We have seen the safety trials, the results of the trial, the verified trial, and other things. So it all definitely qualifies for a good agent to add as an add-on to metformin, as well as rightly said, we can start as a monotherapy also. But for any treatment of diabetes, you need to have good monitoring, a regular follow-up, and you need to emphasize all these points to the patient. It should not happen that the patient takes a prescription for diabetes and he just comes to you after 1 year, 2 year down the line, and then it becomes very challenging to manage diabetes as well as save his other organs from getting affected. So definitely, whenever a new molecule comes in the market, it's in a patent, and then few companies, only one company will have the authority to manufacture as well as distribute these products. So whenever there is a monopoly, then definitely the cost is high, availability is a concern, and all those things. But as we are seeing, a lot of drugs are getting out of patent, and I think I would like all the panelists to one by one, to start it with Akshay, I would say, to reply to this thing. So, what is your take on vildagliptin post loss of patent era?
The post-loss of patent era, sir, has been really awarding, and it's been really a boon in disguise to our patients. I clearly remember when vildagliptin was launched back, I guess, in 2008, by Novartis. The
Novartis.
cost of therapy was so high, and I was working in CEM as a resident. It was almost impractical for us to use vildagliptin at that day and age. And now things have drastically changed, and they've changed for good. Now there are so many companies with vildagliptin, and the cost of therapy has drastically come down to such a low level that it is really a successful story compared to for the diabetic patients as such. So definitely the cost of therapy and the associated competition with the in terms of vildagliptin has brought smiles to the faces of diabetic patients. So that's been really a good thing.
Yeah, Dr. Mitesh, you would like to add something for this?
Yes, I think the loss of patent of vildagliptin has been of utmost importance. I think to the patients more than anyone else. I think because of its molecular efficacies and molecular differences with other molecules, its effectiveness in controlling the root cause of diabetes, as has been correctly said. I think it's glucagon and the incretin and the insulin releasing and the decreasing effects, plus the effects on the gastric emptying time and everything related to the DPP4 per se. I think it's been an excellent add-on therapy for almost a very good proportion of diabetic patients. I see a lot of prescriptions. The majorly used drug, I think, these days of all the gliptins, I think, is vildagliptin for sure. I think yes, and it's scoring above all the other gliptins as well. I think yes, and it's very valuable, I think, to everyone.
Yeah. Dr. Abdul Shakur?
Nothing is left, both and you also said, but basically definitely is true, since one of the good molecule and the cost was the problem for our middle class population, and especially even monotherapy wise or add-on therapy with other molecules, metformin or with DPP4 or with SGLT2 also combination, or with even insulin. So it's a good thing for our patient and for good for all of us also to prescribe and to get a good result for our patients. So it was a good discussion among all of us four people. And when Hari Safree was there, I was very happy because really, even as a speaker, I have not heard, but as a moderator, really, he is better than other people. Last time also he was there. And
thank you for your words of appreciation, Dr.
To take on, I have seen. No, because this two has not seen you before, maybe I don't know. But I saw you last time also. Because sometimes moderator is also very, because even somebody we don't know, we three might have said correctly, but even the way he takes
Yes,
our train
and I
on
think
the
it's taken
platform,
into the discussion very well.
that beauty goes, to the moderator, the train takes
Yes.
on to the proper path. That's also beauty of him. And by the grace of Almighty God, he used one good word. India is a Makkah Madina of diabetes.
Yes.
So in the word you use, he was exactly correctly you used. And even Dr. Gala used a different way, but same word was there. The terminology was different. And all the even we all four were going for one platform only.
Yes, I think.
Yeah, it's always better to have panelists like you where we can discuss things, can share their experience as well as expertise, and as well as to discuss the. So if the panelists are really good, the job of the moderator becomes very easy. And I think I was very fortunate to get you all here.
Dr. Damleji बरोबर बोलतो का नाही मी
एकदम
moderator
sir.
is the main person.
Absolutely, sir.
So anyway, it was very nice these things, because today I had two other before lecture. One was for Sanofi on insulin, And today still I'm in clinic. So just by 7 I took my lunch because patients were there, and now patients are also there. But again, since yesterday, little COVID and season started. Last week was little slack, but since yesterday, little this thing, because this is my daycare center from where I'm taking lecture.
Good,
Great.
good. If any panelist has to have say some comments about whatever we have discussed till now, or I think Mandar, are there any questions from the audience that
Sir, on
questioned
this
till now?
platform, unfortunately, that facility is not there.
Oh,
So
okay.
that we can have that, and precisely that is the reason we have kept question and answer session, so that we can cover most of the questions in the program itself. So I think we have covered almost everything, and it was a very interactive and fantastic panel discussion. I would like to thank our moderator, Dr. Hari Safree, who has moderated the session so very beautifully, and as has been rightly put by Dr. Abdul Shakur Mukadam. Of course, all the panelists have contributed immensely for the success of today's panel discussion. And Dr. Safree has directed the panel discussion in a very, very right direction. So thank you very much, sir, for coming today and moderating the session. I also would like to thank Dr. Abdul Shakur Mukadam, Dr. Akshay Damble, Dr. Mitesh Gala for their fantastic contribution for today's panel discussion. And before we end today's panel discussion, I would like to definitely say that we are at the end of probably the second wave of COVID has almost ended, and everybody is has crossed his or her fingers that we don't face the third wave of COVID. And with this hope in mind, we say goodbye to everybody. And as a responsible pharmaceutical company, Alchem, the fifth largest pharmaceutical company in India, of course, assure all the panelists as well as the audience that we will ensure that our products like Blue Wilda are available throughout for your patients. So thank you very much, everybody, and good night.
Thank you, Akshay, thank you, Abdul, and
Thank
thanks.
you, sir. Good night, sir.
Okay, bye. Good night.